It's been a while since I've been back to this conference, and it's been really great. The ideas, the sharing, the camaraderie, all that stuff's been really good. I liked Dr. Prasad's lecture earlier. That was fantastic. It's true, there is no rivalry between the U.S. and Canadian Preventive Services task forces. We work together on a lot of things. For the last 2 NAPCRAGs, we've actually presented together about how to address research gaps from each group. Now, to the basketball issue, I would merely refer my colleague to the National Hockey League Stanley Cup final winners for the last, is it 26 years now? Yeah, so just to get over that. The ARC sponsors this conference, and they sponsor the U.S. Preventive Services Task Force, and they do an amazing job. From the medical officers that help us produce the materials, arranging the research from the evidence-based practice centers, from the setting up the communications team that support us. It's really amazing stuff. So we really appreciate their help with that. It's great to see them here. So this is what I'm talking about, prevention and value. I thought of the most creative title I could. These are my disclaimers. I'll talk a little bit about also vaccines, as we're talking about prevention in general. I sit on the Delta Immunizations Work Group for the ACIP, so we'll talk a little bit about that. I will note that the first part of my talk is going to be about task force stuff, and then I sort of take off the task force hat. I don't attribute anything after that to the task force. That's all my fevered musings. So we'll talk a little bit about the mission, methods, and scope of the task force and what we actually do. We'll talk about the challenges of balancing preventive services, chronic care management, and the rest of primary health care. Not that that's difficult at all. And talk about approaches to better integration. Now, this is there's some research in here, but it's largely ideas. So feel free to argue with me during the discussion time. This question intrigued me when Don told me, how do we keep prevention on the table in the face of disease management incentives? The questions that I had were, what table? What table are we talking about? What are we talking about when we're talking about a table? It strikes me they're probably different tables. And I think what people do, rather than when we talk about the ability to achieve value-based care and talk about different metrics, et cetera, is that everybody's bringing their own table into the discussions, not just sitting at the table. They're bringing their own table, and tables are piled in the middle of the room. And it's really hard to get around. So the issue of table struck me as interesting. Is this Sophie's choice? In other words, are we really choosing between taking care of diseases and taking care of prevention? I hope not. I think there probably is while there may not be an active choice, I think there is a de facto decision we make as we go along through the day that crowds one or another out. And we'll get to that in a little bit. And is there a difference between, I just went to Jim Mold's talk on person-centered care, an amazing talk. And is there a difference between prevention and disease management? Most disease management is kind of prevention, and he came to that conclusion. I'd talk about that a little bit later. It's roughly the same thing. We seem to want to separate them. I will note that in my setting, prevention does get crowded out at times. So there ends up being a difference whether there should be or not. I am a primary care physician. I do still see patients. I am an advanced beginner PBRN researcher. As I say, I've been coming to this when it was owned by the NRN. This conference was owned by the NRN. We set up a small practice-based research network in Syracuse when I was there for 18 years. I say we did sort of a handful of studies. I say I'm advanced beginner because I nailed the acronym name for the network, I think. Now you can talk to my co-director, Chris Morley, and he doesn't like it so much, but I think I nailed it. That's why I'm advanced. Population health. I moved from Syracuse 2 years ago down to Virginia Tech to the Carilion Clinic, where they had just started this journey called the Next Generation ACO, Accountable Care Organization. And this is full risk management where real money's on the table and everybody was very nervous. We partnered with a company, these companies that go around and doing health analytics and care coordination services to achieve the metrics in the ACO. And the ACO is constantly on a potential chopping block as the CEOs and CFOs of the clinic get very nervous about whether or not we're going to lose money this year or next year. This is a new direction. We're learning new things. We're doing new things at Carilion Clinic about this value-based care stuff, and it's relatively high stakes. We have applied some of this. One of my roles is as medical director of employee health for the Carilion Clinic, where I get involved in health plan decisions and other employee health matters. And we've adopted some of this population health management strategy for the employees. It's a different setting. It works a little bit differently. There's a different kind of population and goals, et cetera. But we are full into this. And then I've been a task force member since 2016. So what is task force and what does it do? And why do we talk about methods so much? I think we're really concerned about explaining our methods and making sure that people are up to date with our methods. We think it's important. We'll talk a little bit about who we are, what's our scope, how do we get topics, how we weigh evidence, make recommendations, and disseminate the recommendations. We think the methods are important because it's best summed up by this Institute of Medicine, now National Academy of Medicine publication about clinical practice guidelines we can trust. We take this pretty seriously. We want, and I think we have a good amount of trust in the primary care community, especially family medicine, internal medicine to a large extent. And I think it's really important that we adhere to these principles. And this publication listed this sort of map of how you develop evidence-based guidelines that we can trust. On the top left there's defining the clinical problem, developing the systematic reviews on the top right, and that has a cycle to it. You need a good group to be able to do that. And then the development of the clinical practice guidelines is where lots of guidelines take different perspectives about how they use this evidence. It's pretty easy to, or not easy, it's straightforward to do a systematic review and get your results from a systematic review. It's what you do with that information on this bottom end that ends up being important. So we have a very explicit methods manual that talks about how we appraise the systematic review results, how we incorporate expert opinion, and how we produce our guidelines. Now, it's nice, we get all sorts of questions as I present on behalf of the task force. We get asked about how we treat diseases sometimes. We get accused in various ways of working with drug companies to promote their medications. We get asked about vaccines a lot. We get asked, why don't we have real experts in the conditions you're talking about on your committee, and why wouldn't you do this? And then what do we think about such and such law or policy or regulation? We don't do any of that, and it's sometimes a frustrating answer for folks as we go through that. But it's important to stay in our lane and say, this is our lane, and we want to, it gets back to trust a little bit. If we're veering off into other lanes, we want to avoid that and talk about clinical preventive services, which is what we do. So we make recommendations on clinical preventive services. These are services delivered in the primary care setting, referred to by a primary care clinician. So it can be stuff that we do in our practices, or it can be stuff that we would relatively easily refer out into the community. And that, I have on the bottom right that the community services are talked about by the Community Preventive Services Task Force, sponsored by the CDC, where we look at larger community services, things developed by public health or government or community service agencies as part of population prevention. We're very much focused on clinical prevention. That line can get a little blurry when we talk about our obesity counseling recommendations. When we talk about scoliosis, there are things that are done in the community. Scoliosis is a great example. School-based screening in scoliosis, is that a community preventive service, or is that something that primary care physicians can use the data from? Should we do it one way or the other? Obesity counseling takes an enormous amount of effort and is rarely able to be delivered in a primary care setting, given that it takes upwards of 26 hours to be able to affect a change in obesity for children, for instance. It's hard to do that in a primary care setting unless you have cooperation from outside agencies. So that line gets a little blurry, but we again try to stick to what primary care clinicians would sort of directly organize or do. And they're applied to adults and children without signs or symptoms. Dr. Prasad brought up the issue of depression, and that's a thorny one, right? Because the screening instrument of that is asking about symptoms. Symptoms aren't necessarily readily apparent when you're looking at a patient, although sometimes they can be. And so that line between what depression screening is and whether or not somebody has symptoms often gets a little fuzzy. And we discuss that a lot, actually. Our scope is primarily on screening tests, counseling, and preventive medications. We leave vaccines to the ACIP, the CDC. We have 16 members from all the primary care specialties and nursing and behavioral health. We have a chair and 2 vice chairs. They serve 4-year terms. Alex Christ is a vice chair now. He's in his 2nd vice chair year. Will be chair next year. 4-year terms. They're appointed by the ARC director with guidance from the chairs and vice chairs. There is a rigorous, and I mean rigorous, review of conflicts of interest. We go through open payments. We go through listing absolutely everything we did that it could even have any relationship to money, and we hold to that. We list disclosures, et cetera. Again, all this is about trust. Trust stems from we are the primary care physicians that would be doing the recommendations that we come up with, so we know the context, we know what goes on. The conflicts of interest is so that we understand what, or so that the public can understand to what extent we're potentially influenced by industry, which is essentially none. You can read all about us. Our bios are up on that page. Our development process, you can nominate a topic. We talked a little bit about the social determinants topic that in fact has been nominated to the task force by my academy, the American Academy of Family Physicians. We're currently working on that. We're working on figuring out whether we should work on it, I should say that. It's in the topic prioritization process right now. The draft and final research plans, we create a research plan in conjunction with the Evidence-Based Practice Center, create the plan for how we're going to sketch out, how we're going to think about the particular topic. If it's a recurring topic, how we're going to change it, what worked last time, what didn't seem to work, do we need to change up the topic, do we need to consider other evidence, et cetera. Publish that research plan, allow for comments, and then finalize that research plan. The EPC takes the topic, goes off for what ends up being about a year, and then comes back with the evidence. From that evidence, we work through our process that I'll detail in a second, preparing our recommendation statement, and that's a very specific process that we'll go through. We publish that for comments by the public. We also send a lot of these, the systematic review is also sent out for different expert opinions. So one of the things we get criticized about a decent amount is that we don't have experts on our task force. And while that's true, we do go out of our way to solicit expert opinion. Expert opinion on the draft research plan, expert opinion on the draft evidence review, mostly in the sense that we ask them, is there evidence that we missed? Is there something that we're, in the conceptual framework here that we're not thinking about? Not necessarily feedback about our recommendation, because we regard that as the primacy of the primary care clinicians on the task force. The public comment period we talked about, now this is, Don asked, when he asked for a little explanation of the task force, he said, we want to get under the hood of the task force and see how the recommendations are made. Well, we don't have a hood. We're driving down the freeway, the engine's exposed, everything else. And the engine exposed is the procedure manual. This is really, really important. And also, if you can't sleep at night and want to get to sleep, go ahead and read that. It's, it's a dry, long technical document, but it's really central. When we get into arguments about how we're making decisions, we inevitably bring each other back to say, well, our methods manual, we even have our version of a parliamentarian, the assistant scientific director for the task force, acts as our parliamentarian to go, I remember we talked about this in the past, and the methods manual says this. So it's a helpful guide for us. It's very long and detailed. So this is something we call the Analytic Framework. This is how we begin to think about a preventive services recommendation. I'm sorry for dipping into my microphone. I'll try to avoid that. This is for skin cancer prevention, so counseling to prevent skin cancer is the topic here. And the Analytic Framework, there's small writing. I don't need you to see every bit of it here. But over on the left-hand side is where it starts, and you have the patient population. You have an option. If we can find evidence that overarches, takes us from the actual intervention, counseling intervention in this case, to the outcome, that's what we call a KQ1 question. If we have that evidence, great. That's wonderful evidence to rely on. If we don't, we can put together an evidence chain that works step by step here. So it's can we counsel people and get change in sun protection behaviors and avoidance of indoor tanning, for instance. There are harms. The orange dots, number 3 labeled there, are the potential harms from counseling for that. And it's something we take very seriously, is there is this, and we'll talk about it a little bit later, the balance between the benefit and the harms. Does that sun protection behavior then lead to intermediate outcomes being changed and then ultimately to the big ticket health outcomes? Are there intermediate steps that involve benefits and harms, so treatments, et cetera? So that's one example of how we do that framework. This is the one for HIV screening. The recommendation that came out a couple weeks ago is a combined recommendation about HIV screening, which we continue to give an A for, and also HIV PrEP, the pre-exposure prophylaxis medication. This is our framework for HIV screening, and again, if we can screen and influence health outcomes, that's key question 1. If not, we can go through the screening process or the harms associated with screening, go to the interventions. Do the interventions work on a screen-detected population? That's an important key. And then are there harms associated with those interventions? So that's how we begin to think about this. And this, plus the narrative part of our plan, is what goes out for public comment. Now, the letter grades. This is how we come up with our recommendation, if you will. So we have a grid, and this grid, just as you see it here, is posted at all of our meetings. And we weigh 2 things. We weigh the certainty of the net benefit. So that is how good the literature is, how high quality the literature is, how much literature there is about it that allows us to make a determination to begin with. So that's certainty of the evidence, and we grade that high, moderate to low. And then we talk about the magnitude of the net benefit. So this is the benefits shown by the research minus the harms, either shown by the research, or sometimes we extrapolate that. We use a process called conceptual bounding. If we don't have any data about the harms, we figure what's the worst harm could come from that. And that's one of those judgment opportunities that happens down in that right lower circle of the evidence process that we think is important for us to be able to make recommendations. We try to use evidence as much as we can on that harms thing. It doesn't come up that we have no evidence very frequently, but occasionally we will use that conceptual bounding. Importantly, and one of the things that differentiates us from a lot of guideline groups is we don't fill in what we don't know. So if the certainty of the evidence is low, we do not fill that in with a recommendation. We call that an insufficient evidence. That's the thing that should generate the most trust and yet frustrates people the most, and we recognize that. We'd like to be able to get off I recommendations as much as possible, but we choose not to make recommendations in the absence of evidence. It takes a lot to get an A recommendation, substantial net benefit, and very high certainty. HIV screening meets that. HIV PrEP actually meets that. Moderates, immediately surrounding the A are the moderate benefits. You'll see most of our positive recommendations are B recommendations. The C recommendations, we'll talk about these in a little bit, but they're basically a small net benefit. So whatever the intervention is, has a small net benefit. The evidence is good, or at least decent, but the benefit is small. This used to be talked about that the difference between the harms and benefits was too close to call. Here, it's not that uncertainty, it's that the net benefit is kind of small. 0 and negative get a D. Just because a prevention opportunity doesn't have any net benefit, if it has a 0 net benefit, that's not an excuse for just going ahead and doing it anyway. If something has a 0 net benefit, then we say we shouldn't be doing that. It takes time, it's opportunity cost associated with it. We give that a D recommendation just as if it caused harm. So this magnitude of benefit versus magnitude of harm thing is really important. And we talked a little bit about the harm data is traditionally really hard to get. We develop mostly from the randomized controlled trials of the interventions that we look at. We do develop what we call contextual questions to look at harm sometimes. These are sort of not in the analytic framework, but might influence it a little bit. The EPCs produce those for us. But this is the essential question. This is what, we do podcasts for JAMA. JAMA is our current publication partner. And on every JAMA podcast, the editor-in-chief makes a point of saying, you know what the task force does best is to consider both the benefits and the harms. So we do take that very seriously. The magnitude of the benefit, there are two actual C recommendations. So when the benefit is pretty small, the magnitude of the net benefit is pretty small, there are a couple different flavors of that. There is a flavor where you might actually talk to the patient about it, a shared decision-making model. And should we, oh, there, I don't know what's going on. Other considerations. We may not choose to offer this. And that has a lot to do with the actual preventive services. If it's a counseling, so skin cancer, we'll get to this in a second. Skin cancer is a counseling recommendation. There's a C part of that recommendation. You can't sort of have a shared decision-making about whether you're going to counsel somebody, obviously. So you either decide to counsel based on what you know about the patient or not. So there are different ways to cut this magnitude of benefit, magnitude of harm thing. And then there's the nature of the harms. There's a lot more research to be done on this. The nature of the harms can be the actual harms, allergies and nausea and side effects of medications and all the stuff you would think of as harms. They can be things like labeling, if we're doing counseling interventions, labeling, excess attention to a topic that may cause side effects down the road or effects down the road. And then we have a class of harms that we argue a lot about, and that's anxiety and worry. So this comes up in places like breast cancer, prostate cancer, et cetera. When you're getting a test, it comes up positive, and you have an uncertain outcome down the road, we feel like anxiety and concern and the effects of that are important to patients, but there's relatively little guidance on how to weigh those and value those. And so these harms that we know probably exist, we have a hard time quantifying, and that's one of the major criticisms we get for some of our C recommendations and others, is that if we're valuing or suspect that the harms are significant, that we may get argument from other folks that the harms aren't. Now, usually it's from specialists who have a different investment in the topic, but that's the way. And then most of you all know this, the A and B recommendations we generally advise doing. C recommendations we talk about either offering or this service for selected patients or having a shared decision-making conversation. So it could be either D, we generally recommend discouraging, not doing the service, and the I, we make no recommendation. This is an opportunity if you need to engage or not engage, but it shouldn't be directed by the evidence. Again, we can get lots of opportunities for input. We do actually read every single comment. For our cervical cancer screening recommendation, there were upwards of 800 comments. And so we read every one of them. We read all the comments on the research plans. We read all the topic nominations and give those a vetting as to whether they're appropriate for us to do. So we do read everything. How do you find them? Well, it's all on the website. We're a modern organization. We have a website. It's a wonderful website. ARC and the communications team run this. Lots of stuff going on here. Lots of information you can look at. Top left is our recommendation site. This is where you can search for recommendations. You can either browse all of them or search for them. Pretty easy to do. This is a typical recommendation page. This is for colorectal cancer screening. You see up on the top right, that's where you can get to the recommendation statement. There are also several other links. There's text about the top line. So these colored sections are our top line recommendations. And if you know anything about the task force, this is what we really wrestle about these words, as all 16 of us really focus on these words. One, because, and I'll talk about this a little later, we know that people generally read the top line recommendation and sort of stop there. Our recommendation statements are much longer than this, pages and pages. But most people we know stop there. And so we want to make sure that we're delivering the right messages in the top line recommendations. But there's other stuff. There's information for patients and for clinicians, supporting documents. You can get to all of our documents, evidence, et cetera. There is an app for that. It's currently sort of app 1.0 looking. We're looking to improve that a little bit, and we're doing some work at trying to figure that out. It's called the EPSS, Electronic Preventive Services Selector. It's fairly easy to find on the app stores, so if you just type in U.S. Preventive Services Task Force, you can find it. It's available for all those different programs, all those different platforms. That's one way to get our recommendations out. I'm chair of the D&I work group, the Dissemination Implementation Work Group of the task force. And this is how we've sort of conceptualized our work for the next few years, that we are mainly focused on the left side of the block, which is dissemination. But we have a number of structures where we've really partnered with partners and stakeholders for the implementation and the crossover between what we produce as our products, our recommendation statements, and how we get those into practice. So we have a list of our D&I partners, are a set of federal partners, NIH, et cetera, CDC, that we work with very closely to figure out how we can share information across the different organizations, but also a whole section of non-federal partners. So these are everybody from the different specialty societies, American Academy of Family Physicians, ACP, nurse practitioner societies, PA societies. There are also folks like the National Quality Forum, the National Business Group on Health. So these are folks that are connected and have a vested interest in our prevention recommendations. And we work with them in several different ways, but mainly to get the word out about our recommendations and find out how we can do that better, how we can assist them in notifying their constituencies of our recommendations. Our work has mainly focused on communicating that dissemination piece, communicating our recommendations clearly. We have just completed about a year-long project working with the Scientific Resource Center that ARC contracts with, that's helped us ask clinicians, D&I experts, and other stakeholders about how our recommendation statements are actually used and read and what could be changed in them. We get feedback from JAMA, we get feedback from all those different places about what can we do to improve our recommendation statements. We realize, and I won't go into all the details of that particular finding, but as I said before, when we interviewed clinicians, they generally stopped at the top line. We put a lot of effort into the rest of the recommendation statement and drawing out what we call the clinical considerations, currently called the clinical consideration sections. And we write that with the clinician in mind. How are you supposed to get this into practice? What tools can you use to get it into practice? How do you make decisions about how to implement this stuff? I wish more clinicians read it, because they don't, apparently. So we're refocusing that, rewriting that a bit, bringing we're reorganizing our entire recommendation statement. Hopefully you can see this more toward the end of the year, to reflect what we've learned in that process. That clinicians, if we're going to put all that work into it, they want good clinical info rapidly. Don't use a lot of scientific words, and how do we get that done best? We have different priorities for that. We need to be able to explain our process, explain the evidence. So we will still do that, but we also need to front load the recommendation with the clinical information. So we work with the media communications team that we have, and in reorganizing that, emphasize again the clinical information. ARC is also has a larger clinical decision support project, and we have been working with that project for a while. The goal of this is to be able to, whatever we produce in terms of clinical recommendations, is to get that fed into our various electronic, I was going to say systems, but sometimes I mean overlords, electronic systems, to get it in practice a little bit better. And that means the EHR. How do we get our information more machine readable and more easier to implement into the diversity of electronic health records? But also, are there other ways that we can use this electronic connectivity to get our recommendations out there? And what do we have to do with our recommendation statements to make it more likely that those can get out there? We're having a health IT forum where we're bringing numerous folks from technology fields and health IT into a meeting in a couple of weeks to talk about some best practices for this. So that's the official part. I'll throw my task force hat away here and talk a little bit about prevention and primary care. I have some perspective on this, being a primary care physician. I watch our clinicians in our ACO network struggle with this a little bit, so I have some ideas. This quote is probably a bit apocryphal, but is attributed to Kevin Grumbach when he came and talked to the Virginia Academy of Family Physicians. And he didn't mean that he was never going to order a colonoscopy again. I feel fairly certain of that. What he meant was we're generally trying to reorganize our system so that some of the stuff becomes default and clinicians don't have to think about it. And that's what he meant. I never want to have to order a colonoscopy again. I just want it to happen. That's what we talk about when we talk about working to license, when we talk about getting our teams to be efficient, et cetera. Is there a downside to that? Is there something that's lost if we're not thinking about prevention? I'm going to argue a little bit that there might be, and so we need to at least think about this. When we think about prevention, our sort of leading principles, I think we've mostly given up on this whole idea that prevention it costs less than cure. We think it's probably still better than cure, but it may not actually cost all that much less. We do believe, and I've heard this several times in this conference already, that prevention is integral to primary care. And I'm going to continue to make that case because I think it is. And the discussion of prevention, I think, is integral to primary care. But we're faced with a couple of problems. One, the prevention is increasingly complex. The interventions themselves are complex. And that it's increasingly nuanced. There's distinction and difference with those terms. But what I mean by that is it's more difficult to figure out who we should apply these preventive interventions to. Selection, risk assessment, those things are increasingly difficult. And we know from multiple publications, starting with Yarnall back in the early 2000s, I think, to several publications recently that show that if we try to do all the preventive services activities, we don't have time to eat, sleep, walk the dog, anything else. It takes a lot of time to do prevention right. And so we're faced with that issue. I wish I could say I solved this problem by the end of the talk, but I just noticed a problem. Just look at one disease, cardiovascular disease, atherosclerotic cardiovascular disease. There are a number of different things that we could do that are recommended to do, and not recommended later, to just address this one topic. And this is one aspect of our patient's health, a large aspect, admittedly. Smoking cessation, a complex intervention. It requires time, it requires skill to do motivational interviewing or trans-theoretical model or whatever you're using correctly. Healthy eating and physical activity. If we look at a combination of our recommendations over our portfolio about diet and exercise counseling, that tends to work better if you're at higher risk. If you have diabetes, or if you're at high risk for diabetes, or if you have other other cardiovascular risk factors, diet and exercise counseling tends to work better. We see more magnitude of effect that way. As you get lower than that, they convert, so they're B recommendations when they work well, they convert more to C recommendations when you are at lower risk. So not only is the selection and is the nuance difficult, knowing where to apply that diet and exercise recommendation, but also the complexity is, and I referenced this before, that it takes, in both our adult and pediatric recommendations, 26 to 52 hours of intervention to achieve just a change in the BMI. And so that alone can take lots and lots of time. Screening and treating for hypertension, we know with all sorts of with the guideline wars currently going on, that's becoming more complex. The aspirin recommendation. So here we're faced with a evolution of an aspirin recommendation from gender and sex-based for the population of those genders and sexes to now a risk score and a determination of prescription for aspirin if you have a ASCVD risk over 10%. Or now with the last three, the most recent 3 studies on aspirin coming out in 2018, and we don't have a recommendation on this. We haven't looked at it yet, but we have it pending, I think. I've started to de-implement some of this strategy. So that is incredibly complex. I have patients going, wait a second, for the last 10 years, you've been riding me about aspirin. Now I don't take aspirin? What, I mean, you sort of knew about all this stuff, didn't you? And I said, well, we talked about it. We talked about bleeding risk, but now just none of this. And I use the evidence when I talk about it, and the evidence is important, but there's still that, you get the sense that you've lost a little bit of trust when you talk to your patients about that. And that's how do we navigate that de-implementation discussion, I think is important. Statin use, we all know the vagaries of that, I think, and we're seeing those guidelines change, so that's another aspect of statin wars. How do you convince patients that certain things aren't useful? So CRP testing, blanking on this, CRP testing, the ankle brachial index testing, the coronary artery calcium score. So they have been shown to be somewhat predictive of heart disease, atherosclerotic vascular disease, but lack we lack the translation from we find you're at high risk to being able to prevent heart disease. And there are all sorts of issues with poor reclassification and discrimination, et cetera. EKG screening isn't particularly useful in cardiovascular disease prevention, but you have to talk patients into that occasionally. And AAA screening is applicable to some, not applicable to some. We're doing Medicare annual wellness visits. It says AAA. We got to know to whom that applies. We have to have the information to be able to apply that recommendation. Vaccinations are a whole other issue here. So I just finally had to, after years of struggling, a couple years of struggling with my practice, I finally grabbed the whole practice together and explained the pneumococcal vaccinations again. And it took, a good 20 minutes, but in boiling down and thinking of new ways to be able to talk about this, there are still questions with this, and this has caused a bunch of different errors in vaccines, et cetera. HPV vaccine, we all know the difficulties in getting that. I think it's helpful that the ACIP has reduced the necessary shots for those that get it before 15, but simultaneously they've also increased the age limit up above, so it's hard. Zoster vaccine, explain to your patient who thinks they're done with the shingles vaccine that, oh, wait, we got one more for you. There's a whole, and it's 2 shots this time, and you still got to get in the pharmacy because for some reason we can't pay for it. Medicare, there's a lot that goes on in vaccines and prevention that's both complex and nuanced. I think these are good places for primary care research, especially for PBRNs, when we talk about how to work on these vaccine issues. I think this issue of hesitancy is really important, and I think we're finding this constant battle of trust and having to explain to patients something that we thought was settled material quite a long ago. There is this issue of the default position for the CDC now is to offer HPV vaccine as a default, that you are due for HPV vaccine, which is a bit of and as I've presented that in other forums, I get the reaction that's a bit paternalistic, isn't it, that you're not offering folks a choice on the vaccines, even though it might be a good choice. So this issue of paternalism and presenting something as default versus the shared decision making gets people going a little bit. So if we're to think about how we approach these different recommendations, I've heard a lot about focusing on the most impactful preventive services. And that's absolutely a good idea. It's on the at the policy level that just makes sense. You focus on the things that have the biggest impact. There's still difficulty with that. One of my favorite analogies about any sort of behavior change, whether it be physician or patient, and I do mean to call out both physician and patient behavior change because I think both are applicable in the preventive services delivery. You have this metaphor of a rider riding an elephant down a path and trying to get from point A to point B. You need to educate the rider, telling the rider where point B is, how to get there, how to navigate. You have the elephant, who is this big emotional creature that's very hard to actually physically control. The rider, who is very smart, has to be able to control and use these other motivational tools to get the elephant walking down the path. And then the whole process can be easier if the path is a little smoother and easier to walk down, right? So it's a useful way. I've used this for years. Jonathan Haidt came up with it, I think, at UVA. I've used this metaphor for years where when you're talking about behavior change, that you talk about, even patients can use this a little bit, tricking themselves into the behavior that they hope to see, smoothing the path if you're talking about diet counseling, using smaller plates, et cetera. Just finding structural ways and motivating ways to accomplish preventive services. That's still a lot of work. So for the stuff that we already know works, all that work has to happen in order to get those interventions in a more successful way. But then we talk about these recommendations. So we have options. We could just ignore these recommendations. I hope we don't, because I think there are some important things to think about in these. Look at that puppy. That is our prostate cancer screening recommendation. You're welcome. All right. So we got some guff from this at the AAFP meeting. A very beloved EBM presenter said basically, well, the task force didn't do us any favors producing this. You're right. I guess we didn't. Our previous recommendation from 2012 was that we recommended against it. We changed this recommendation based on evidence. There was additional evidence from the European trial that showed additional benefit, and that benefit had increased over that amount of time. That was sufficient for us to change a recommendation. What I will tell you is that most of what we put in this top line here about educating the patient about risks and benefits and not just either doing or not doing a prostate cancer screening without talking to the patient, all that stuff was in our recommendation, even our D recommendation, but it was in that practice consideration section that we were told nobody reads. We feel like it's really important for clinicians to engage in their patients about this recommendation. Why? One, because there is potential benefit. I will grant you that it's not much, that's why we gave it a C recommendation, but there is potential benefit. Two, because this is all over the place, and we ignore a well-known preventive service, I think, at our peril. And so I think it's important that we have these discussions. It's not easy to have this discussion. This is we think it's important enough to have this discussion that we created a graphic about it, actually. The communications people created it for us, that talks about the benefits and risks of prostate cancer screening. How many people have seen this? Not enough, nowhere near enough. So we have, out of the 1,000 patients that may be screened, the bottom line here is that you prevent one, down in the middle center there, of avoiding death from prostate cancer, 3 people on the left avoiding metastatic disease, 5 will still die of prostate cancer, no matter what you do. There's a 20 to 50% risk of overdiagnosis. You have the rates of erectile dysfunction and urinary incontinence there. This has helped patients that I've pulled this up in the exam room. I can get to it fairly easily now, and I can pull it up in the exam room and have these discussions with patients. They say it helps. It's one way that we look at of doing that. I'll notice that I'll often talk with patients about what sort of guy they are. Are they if it ain't broke, don't fix it kind of guy, or are they I'm concerned about cancer, I want to make sure I don't have cancer. Cancer is very important to me. And even though it sometimes feels like you're shortcutting a little bit, that's basically what we're asking folks to tell us about. Tell us about what your values are, how you think about prevention, and how does that relate to this. These are the 2 types of C recommendations I talked about before. Breast cancer screening. Breast cancer screening is what we recommend as shared decision making. You'll notice the amount of verbiage here, and yes, there is a direct correlation between letter grade and amount of words in the top line. Our breast cancer screening talks about the risks of false positives. It talks about the risks of further the anxiety and worry associated with those false positives. And that's what we intend to be a shared decision-making conversation. And then skin cancer counseling is a different one. That's skin cancer counseling. We give a B recommendation to children from age 6 to young adults age 24 with fair skin types. So that's our term for red hair, freckles, easily burned, those type of things. The C recommendations for people older than 24. The magnitude of benefit is pretty darn small for that group. Now, again, you can't counsel somebody, have a shared decision-making conversation about whether you're going to counsel somebody or not. That doesn't make sense. So you have to work with, if somebody's real fair-skinned, or I know of a family history of skin cancer or these other risk factors, I think it's important to go ahead and do that. It requires reading the recommendation and knowing the recommendation really well, because those risk factors are listed in the recommendation statement. What are the sorts of things that might cause you to counsel a patient like this? What do you need to do? I think that's important to know. Calcium, vitamin D, this is a brief one. This is about the evidence changing. Again, we had a B recommendation in 2013 for older adults who are at risk for falls to give them vitamin D. We have more evidence and are more uncertain. That's actually happened a lot. Happened with scoliosis. We had a D recommendation against scoliosis. We have more evidence now, good evidence about a bracing trial. We are now more uncertain about what to do with scoliosis than we used to be. It's now an I recommendation. So that happens. Keeping on top of that, being able to de-implement or de-prescribe is important. So I think that our opportunities here with CD and I recommendations are to really, I think we have to educate the writer on these pretty much, that folks need to understand the science and the recommendation. That understanding the patient's values and preferences, these recommendations set up a chance for you to talk to your patient and understand their values and preferences. Jim Mold's talk just now was about relationship-oriented care, person-centered care. I got the term right. Incredibly important, and he was talking about way more than this, but I think it's really important. I think this is a foundational aspect of primary care, and having these discussions about these more controversial topics, things that you need to either not do or talk to a patient before doing, help establish the relationships that are foundational to primary care. And I think that's why I recommend those. Building the relationship. This idea of low-value care, we're doing some research on vitamin D. Vitamin D is my sort of whipping boy for a lot of this stuff. We're doing a project looking at the cascade effects of unindicated vitamin D tests. And it costs a lot, and it gets patients into lots of diagnoses and procedures and medications, et cetera. So understanding what low-value care is, the D recommendations or maybe the I recommendations, and getting rid of those and explaining to the patients why you might be doing that. And avoiding unnecessary opportunity cost. Every unindicated thing we do takes time from the indicated things we might do. So understanding what that cost-benefit trade-off is, only engaging in things that are really important with the patients. I think behavioral economics has a principle. So here's a table, and I think the table here, when we talk about tables, is the table of the mind of the clinician and the mind of the patient. And it's a war about those. Behavioral economics, and it comes from psychology and economics a little bit. It's these popular books here, the Thinking Fast and Slow and Nudge and Scarcity. These are cognitive biases or heuristics that we get into that can alter our decision making for seemingly irrational reasons. So framing, we know framing well, right? If we present the risk of something as a potential for benefit, people tend to buy it more than if it's a risk for harm. So just how we phrase the discussion is important. Delay discounting, valuing the pizza that you're eating now versus your weight loss goal in the future, also called present bias. That's very important, and the Research Institute of Virginia Tech that's looking at that very hard on diabetes, weight loss, et cetera. Interpretation of risk aversion. We know most patients are risk averse, so if it's presented as risk, they will avoid it. Gambler's fallacy, on average, things, the idea that if something hasn't happened, it's more likely to happen the next time. Dunning-Kruger effect is overconfidence bias. Decision fatigue at the end of the day, and this has been borne out by some clinical research, at the end of the day, physicians perform more poorly on decisions that require effort, and because they just get tired. There's decision fatigue. And then scarcity. This is perhaps the most concerning one to me. This says that people's measured intelligence, IQ scores, et cetera, go down when they're in a situation of perceived scarcity. And that scarcity can be time scarcity, financial scarcity, et cetera. And they make poorer decisions. So the poor make poorer decisions, unfortunately. So what does that say about when we're counseling people for preventive services and they're fighting scarcity in their own lives? Are they able to make the good decisions about prevention? I think this stuff is ripe for understanding more about how we deliver preventive services. I think we can frame them better. There's an intervention called episodic future thinking, where if you get people to think about the future more, just in general, not specifically about the prevention activity, but if you just get them thinking more about it, that will counter delay discounting in some settings. And then choice architecture or nudging, this is a little bit of that paternalism. How do you construct it so it's easy for people to make the right decisions? Some of that path smoothing. And metrics. Let's tackle metrics. This book, somewhat of a polemic book, called The Tyranny of Metrics. You couldn't guess by the title, right? There are things that we measure, there are things that are worth measuring, but what can be measured is not always worth measuring. We've heard that before, we kind of get that. Certainly in family medicine, we are inherently skeptical about these things. What gets measured may have no relationship to what we really want to know. I worry about that for many of the disease metrics and quality metrics that are in our ACO environments right now. The cost of measure may be greater than the benefits. We know this is the case. At Carillion, we have measured, one of my colleagues works a lot with burnout, and we have measured our clinicians in family medicine as having a moderate to high risk of burnout. 50 to 60% of our clinicians are at high risk for burnout. And a lot of it has to do with, it's blamed on the electronic medical record, but it's this other work that the EHR is into, the value metrics, et cetera. Things that we get measured may draw effort away from the things that we really care about. So this is the spotlight effect. And we know that this happens in practice a little bit. We need to be measuring the stuff that we aren't focusing on with our interventions to make sure this isn't happening. and measurement may provide us with assorted knowledge. We call these things quality. We call them quality metrics. Are they really quality metrics? Or are we missing the important things in primary care family medicine, relationships, patient well-being, those type of things? I did a study a long time ago now where I asked a bunch of people if what made somebody an evidence-based practitioner. And I was expecting things like, 80% of the time they do the right thing and other sort of quality-focused metrics. We were interested in measuring the extent to which people were practicing evidence-based medicine. What we got back, and I should have known, was a set of personality characteristics: honesty, skepticism, relationship building, these type of things. So we knew, and unfortunately I couldn't get this published anywhere, but I knew from a very early stage that when people talked about, even when we narrowed the question to evidence-based medicine, people were talking about quality, and it had more to do with personality characteristics and your approach to things than it did about metrics. Pay for performance, we know the problems with that, limitations of what that's able to describe, the gaming that goes on. So we know from some literature that if you make the game too high stakes, then people don't perform any better. So that's some of Daniel Pink's work. And that the best way to incentivize people is to have a small benefit and select the right people for the right sort of outcomes. But we find in Carilion that our docs have a fairly limited incentive bonus, and they just see more patients rather than messing with all this value stuff. So I think there's a real issue with trying to figure that out. And we talked about Spotlight. I looked at the 2019 HEDIS measure set. The question is prevention on the table? In the clinical effectiveness measures, fully 31% of them could be described as prevention, and that's even not categorizing the disease metrics as prevention. This is just plain old clinical prevention like the task force would talk about. In the utilization metrics, 17% of them, and in the electronic data systems measures for HEDIS, 43% of them. So prevention, at least as measured by the people that say that they do the measuring, is pretty much on the table. Obviously, you can choose which HEDIS measures you focus on, et cetera. There is a gradually increasing tendency toward composite metrics. These things that say if you do all of the high priority vaccines or all of the high priority preventive services, then and only then will you qualify for that metric. And so that's coming down the road. So we have that to look forward to. I do think ultimately that that metrics and pay for performance, I do think that keeps it on the table. I think we need to argue for how that looks. In Carilion, we are measured by a scorecard. This is a sort of a pay for performance sort of arrangement where we focus on 6 measures for a year and get paid according to that. Prevention hasn't yet broken into the scorecard for as long as we've been doing it, despite my standing in the corner and yelling. So I think arguing in our local systems about the inclusion of prevention is important to keep it on the table. How are we doing? The HEDIS results from 2017. Immunizations, not great. Cervical cancer screening, there are some highlights there. 74%, this is nationally, all the health plans that are participating, all the people that are submitting HEDIS data here. What I like about this is they have some D elements at the bottom there, cervical cancer screening in adolescents. We do a good job of not doing that, so that's good. It's still a little high. PSA for older men over age 75, not recommended by anybody currently, urologists, anybody else. We still do probably too much of that. Arlene Bierman will recognize this graph. This is a paper published by them, some ARC medical officers, Arlene, et cetera, about if one of these composite measures, how many people actually qualify for all or have done all the high priority preventive services. And those look like pretty robust columns there until you look over at the graph and at the y-axis, and it's only 10%. So we're not doing a good job at getting everybody all of the preventive services they need. And so this should definitely give us pause. So I think research directions that we need, the task force gives a report to Congress every year about research gaps. We publish those. That's probably too big for your average PBRN to encounter, although I imagine the larger PBRNs could contribute to that. But we need evidence of effectiveness of therapies in screen-detected populations. So remember that logic model that we did where we can connect the dots? I think we have to make sure that those are, if we do intervention studies to connect screening to interventions, we have to make sure the interventions are in otherwise screen-detected populations, and a lot of the evidence is not in those. Subpopulation evidence. Subpopulations are a term for racial and ethnic and gender, and should the preventive services differ depending on different subpopulations? We have precious little evidence for. It's what we get criticized for on colon cancer, prostate cancer, et cetera. We know breast cancer screening. We know that there are differences. We just don't have the evidence to be able to make differential recommendations. I think PBRNs could help us most with the A and B recommendations by figuring out ways to optimize delivery, and there's been great engagement as long as I've been involved in PBRNs and how to do that. I think the C recommendations, implementing shared decision-making, implementing risk assessment, making sure providers are understanding that and doing that in a high-fidelity way, I think would be one way that PBRNs could do that. And then de-implementation and avoiding low-value care, I think, is another great opportunity for PBRNs. Can we... Helpful. How do we move the needle? Practice transformation. We're still transforming. The Carilion became an NCQA medical home years and years ago, and yet our providers are still struggling with this idea of transforming their practice to be a full patient-centered medical home, or at least that conception of it is. It's not the four-letter term of medical home NCQA. It's really working on the capacity to provide that quality care that's important. Linking them together, there's controversial evidence about this. Do we bundle preventive care, or do we separate it, work on each? I think the drive now is to bundling preventive care and see if we can get more delivered that way. I think that's useful to think about. Not sure if it happens. The health maintenance visit, there's been lots of back and forth about whether a dedicated health maintenance visit is important. I was suspicious of Medicare annual wellness visits, but I'm getting more prevention done with them, and I think other people are seeing that more too. And so I've become a little bit more in favor of health maintenance visits rather than opportunistic prevention. High quality improvement, focusing on preventive service deficiencies. I think exploring this field of behavioral economics has real potential. And you can use behavioral economics for the dark side if you want to. You can be all Darth Vader about it if you want. But I think if you decide to use it for good, I think it's important because I think I'm okay using it because I think the deck's stacked against us. I think there are things going on in social media and between people where the behavioral economics is already being used, whether they realize it or not, and we have to use these behavioral economic ideas in defense of that. Working with community health resources, I don't think relegating prevention to others is a good step completely. I think there are ways you can work on figuring it out, but so we are bullish on primary care in the task force. We depend on primary care to implement our recommendations. I don't think there's any primary care without prevention. Again, most of disease management. I would advocate for embracing the hairball, really understanding what the recommendations are and digging into what we're saying in our recommendations. I think it'll result in better primary care relationships. Prevention, I think, still is on the table. It's on the payer's table. It's on the clinician's table, and there are ways that we can put it better on there. And so I think it remains there, and it's still important. All right. Thank you very much for your time. I suspect I didn't leave much time for questions. I apologize for that.
So that was great. Thank you, John. I think patients need to be our partners in this, in terms of getting the services that are meaningful for them. And I know you're aware of this, but one of the things that ARC is doing is we have EPSS for clinicians. We're actually going to develop patient-facing clinical decision support so that patients can go in and figure out what preventive services they should be getting so they can have a more informed conversation or know what's being missed. So I'd just like to ask you, kind of your perception of the role of the patients.
Yeah, I think it's really important. I think, the doctor recommendation ends up being important. We've seen research that shows that doctors recommending something or clinicians recommending it tends to get done. But there is an issue of driving patients in for that, to have that doctor visit that's important. So both public health and these more patient-facing recommendation tools can be really helpful in that.
So as a primary care physician, we refer a lot of people to urologists for symptoms.
Yeah.
Mostly urinary frequency.
Yeah.
And almost always, I would say in my neck of the woods, 100% of the time they get PSA tests done. So is this penetrating in the urology community at all? And then I had a discussion with one of my urology colleagues recently, just 2 weeks ago, and I said, you know, in our literature, there's not a lot of data for doing this, and recently even rectal exams. And, you know, yet you guys still seem to want to do this all the time. And so where's the balance here?
So who have you been able to change?
Nobody.
I think, you know, what's telling to me is that if you show the urologists their own recommendations, it looks exactly like ours now. We've all come to the same part of a shared decision, and the American Cancer Society too. The 3 recommendations read exactly the same. The urologists have tacked on a number of different sort of other things, but between the ages of 55 and 70, the recommendations are exactly the same. Pointing that out to them doesn't seem to matter, and that is an issue for, I guess, for their society to take up why they're not paying attention to their own guidelines. But I think there are a lot of urologists also that use any symptom, regardless of whether we think it's due to prostate cancer or not, and most urinary frequency symptoms are not attributable to prostate cancer. I think they just look for, I have no idea, I don't know this, but I suspect they just look for reasons to test. It's an issue, but I haven't had any success changing urologists.